Yes, it is.
Yes.
Okay, so I'll just start. So I'll be talking about the histopathology report of colorectal cancer, what a clinician needs to understand. So as we all know that it's a third most commonly diagnosed cancer with 1.84 billion cases that were reported in 2018, and it's a fourth leading cause of cancer mortality worldwide. It's a consequence of multi-step tumorigenesis of several genetic and epigenetic events. The estimated 5-year survival in the metastatic setting is only 13%. So early diagnosis and evidence-based timely management can improve the disease-free survival and overall survival. So the multidisciplinary approach is the need of the hour, and pathologists play a central role in the diagnosis and to determine the prognostic factors that guides the further course of treatment. The role of pathologists has expanded now. The current role has expanded to determine even the predictive, the factors, the mutations for the actionable targets also. So a standardized and well-informative histopathology report is essential. So what are the advantages of the standardized reporting? It enables the standardized diagnosis and treatment. The checklist will ensure that all relevant prognostic factors have been addressed, and it also helps to select the patient's group and exchange the information in multi-center clinical trials or international studies, which is the need of the hour in the current era of extensive research. So meticulous gross examination, it is very important. So a good histopathology report, the prerequisite is a meticulous gross examination. The following parameters needs to be documented in the report, like site, location, extent of the tumor, dimensions, the gross type, is it a polypoidal growth, infiltrative. A diligent inspection of the depth of the invasion of the tumoral and serosal involvement is essential. And we have to submit at least 2 sections from the tumor with the overlying serosa with the closest relation. The gross inspection of the margin, especially the circumferential resection margin, which my colleague Dr. Abhishek has also alluded to, has a great significance. So coming to the some important landmarks like the relationship to the peritoneum. A cecum is entirely covered by the peritoneum but has no mesentery. The ascending and descending colon are retroperitoneal. So they are covered by the serosa and the anterolateral aspect, while the posterior surface lacks the serosal or peritoneal aspect. So the peritoneum is entirely covered by the peritoneum but has no mesentery. The ascending and descending colon are retroperitoneal. So they are covered by the serosa and the anterolateral aspect, while the posterior surface lacks the serosal or peritoneal aspect. So the peritoneum is entirely covered by the peritoneum but has no mesentery. The ascending and descending colon are retroperitoneal. So they are covered by the serosa and the anterolateral aspect, while the posterior surface lacks the serosal or peritoneal aspect. So the peritoneum is entirely covered by the peritoneum but has no mesentery.
Shamir, please check whether Dr. Sunil Pasricha is online or not.
I think he is disconnected.
Sunil sir is disconnected, sir.
Let him join
Okay.
again. No problem.
Sure, sir.
Sharif, Dr. Sharif.
Sharif, are you there?
Yes,
Respond.
I'm here.
Yeah.
Sorry, after this discussion, you will
There is a question. Okay.
ask the questions. After the question and answer session, show me there will be the quiz. Okay.
Sure, sir. I'm ready.
Suman, there should be some selected question discussion only. Majority will be covered in the chat box by the faculties.
Okay. Okay.
So for the maintaining of time, because we have too many presentation today.
Shumon bhai, I am right now selecting copying all the question from the chat box, and forwarded you shortly.
You just pick one question from each station.
So
Okay, only one question.
use the WhatsApp group.
Okay.
Sharif, use the WhatsApp group.
Okay. No problem.
Use the WhatsApp. Abhishek, can you help about Dr. Sunil? Is he Abhishek?
Hello,
Are you
sir.
there?
I want to speak to him, sir.
Okay, please.
I think he is disconnected and trying to reconnect, sir.
So shall we move to our next speaker then, topics, and we can restart with his one?
I think we can wait for 3 minutes,
Yeah,
4
I
minutes.
will wait for, let's wait for 2 minutes and see.
If it is not, then we move to the next one.
Yeah. Okay.
So Dr. Sunil has rejoined.
Okay, so let him share and we start.
Hello.
Yeah, you are audible. We can share it
Yeah,
again.
sorry for some technical glitch. Actually, I have to rejoin.
No problem. No, it's no
No
issue.
problem, it's okay.
So I'm just sharing my slides again.
Please. Please go to slideshow. Yeah,
Yeah. So here I was.
fantastic. Yeah, please go ahead.
Yeah. So the upper 1/3 of the rectum is covered on the anterolateral aspect by the serosa. The middle 1/3 is covered only on the anterior aspect, while the lower 1/3 of the rectum is absolutely bereft of or devoid of the serosa, while the posterior aspect is totally devoid of serosa. So here we have to ink the bare area, like anterior aspect we have to ink the lower 1/3, while on the posterior aspect we ink the whole of the posterior area. So the total mesorectal excision grading documentation in a CA rectum is a very important thing, which my colleague Dr. Abhishek has also alluded. So the surgical plane of the total mesorectal excision encases the rectum, its mesentery, and all regional lymph nodes and constitutes a Waldear's fascia. It is relevant for the lower anterior resection as well as for the abdominoperineal resection specimen. So that is how we grade complete, nearly complete, and incomplete. Depending upon if the mesorectum is intact, smooth, there are no defects, or even if the defects are there, they are very narrow, just not deeper than 5 millimeter. There should be no coning. The CRM should be, that is the circumferential resection margin, should be smooth and regular. For nearly complete, the bulk is in a moderate. There is no visible muscularis propria. The coning is moderate, and CRM is slightly irregular. While for incomplete, the bulk is little. The pits or the defects can be visualized, and they are going deep down to the muscularis propria, and the coning is also significant while the CRM is irregular. So these are some of the photographs from my case libraries, and one can see the complete TME. This is the nearly complete, a very minor defects, but no muscularis propria visible. There is no coning. One can see the bulk is also moderately good. And this is the incomplete TME grade. So one can see that the defects are quite significant. One can see this muscularis propria on the gross inspection. So what are the significance of the complete TME? So a high quality TME surgery has a very miraculous clinical implication. Like a high quality TME surgery reduces the local recurrence from 25 to 9% or even less. The adjuvant therapy in the presence of high quality TME may reduce further local recurrence to 2.6%, and a high quality TME surgery increases the 5-year survival rate from 48 to 68%. And this significance was established long back in 2002. There was a great publication in Journal of Clinical Oncology. It was basically a Dutch trial, and which taken into account 180 patients actually, and out of which 24% but the mesorectum was incomplete. And they had an increased risk of local and distant recurrence of 36.1% versus 20.3% compared with the complete mesorectal, and it was statistically significant 0.02. And from this graph also one can see there is a good prognostic separation of the curves of the complete mesorectum and incomplete mesorectum. So coming to the tumor histopathological type, so we are diagnosing it as per the classification of the WHO, the recent 5th edition, and these are the various histological types which all are familiarized. However, some of the histopathological types, they carry a distinct prognosis, like mucinous carcinomas, the response to chemotherapy is poor. The signet ring cell carcinoma, they have a high incidence of MSI and association with the Lynch syndrome. While medullary carcinoma, they have a good prognosis, high incidence of MSI high and BRAF mutations. Micropapillary carcinoma and serrated adenocarcinoma, they have a poor prognosis, aggressive tumors, high incidence of nodal metastasis. Adenoma like adenocarcinoma has a favorable prognosis associated with KRAS mutations, and undifferentiated carcinoma rarely show MSI instability. Coming to the grading, it is determined by the extent of gland or the tubule formation of the tumor. But one thing is important to know that it is applicable only to the adenocarcinoma NOS type. Other histological types have their own prognosis. For example, medullary carcinoma, although they are poorly differentiated, but they behave as a low-grade tumor and they have a good prognosis. So depending upon the extent of the gland formation, we basically graded well differentiated, moderately, poorly, or undifferentiated carcinoma. Coming to the very important aspect, that is the depth of the invasion. So we are all familiarized with the T staging, and the most important aspect is the challenges is the inter-observer variability in the histological assessment of PT3 versus PT4. So the visceral peritoneal involvement, which is PT4A, is a well-established adverse prognostic factor in stage 2 and stage 3 disease. As per the definition, involvement of serosal lining is diagnostic of T4A. Underreporting of T4A is quite common. Stewart et al. Has reviewed 80 cases of stage 2 colon cancer, and he demonstrated the serosal involvement in 25% of the cases that had originally been reported as free. So what are the reasons for underreporting of PT4A? The prominent fibroinflammatory reaction to the tumor obscures the serosal lining, the mesothelial lining, and making it difficult to confirm the serosal breach. The peritoneal involvement occurs in deep serosal clefts, as frequently the case, which can be easily overlooked. So if you see this figure, so this arrow is showing the clefts in which the serosal involvement is there. On the right side, one can see that. So if the sampling is not done from this particular area, so that is why the meticulous gross examination is very important. So if the section is not taken from this area, we are going to underdiagnose it as T3 instead of T4A. And these are some microscopic challenges, like these are the fibroinflammatory infiltrate just in response to the tumor, and this is the serosa. So this area is somewhat fizzy. It's difficult to take the decision. So at this point of time, as a pathologist, we should take some deeper section and we can demonstrate the tumor many a times.
You need to unmute. You are muted. You need to unmute yourself. Dr. Sunil, okay.
Yeah. Am I audible now?
Yes, you are audible.
Yeah, so the recommendation is that a tumor less than 1 millimeter from the serosal surface with a serosal or fibroinflammatory reaction is unclear. Multiple level section or additional section of the tumor should be examined in such cases for assigning the T stage, and elastic stains are not recommended. So some important considerations for T staging. The presence of lymphovascular tumor emboli is not considered when determining the depth of invasion. For example, if the tumor infiltrates the muscle but LV emboli is seen in the subserosa, it will be considered as T2 and not T3. The intramural extension of the tumor from one subsite into the adjacent subsite does not affect the T classification. For example, a cecal carcinoma invading the ileum or a rectal carcinoma invading the anal canal doesn't amount to upstaging. The transmural extension of the tumor from another organ or site is considered as a T4B designation. So the tumor that is adherent to or the other organ grossly is classified as clinically T4B. However, the T stage will depend on the The pathological T cell will depend on the anatomical or the histological depth of colorectal invasion. The T4A category is not applicable in non-peritonealized portion of the colorectum, including the posterior aspect of the ascending colon and descending colon and lower 1/3 of the rectum. So for example, if this is a case of a ascending colon, so this is the anterior aspect and this is the posterior aspect. So if the tumor is on the anterior aspect and growing anteriorly and breaches the serosa, so it will be labeled as T4, but this is not a margin involvement. Whereas if the tumor is on the posterior aspect arising from the mucosa and goes to the posterior most aspect and reaches up to this dotted line, which is the circumferential resection margin. So this is not a serosal breach. So this will be considered as a T3 with margin involvement. So coming to the lymphovascular emboli, the extramural venous invasion has been demonstrated by multivariate analysis to be an independent adverse prognostic factor in multiple studies and is a risk factor for liver metastasis. So small cell vessels, they include small capillaries, post-capillary venules, and they are devoid of smooth muscle layer and elastic lamina. Small vessel invasion is also associated with lymph node metastasis and adverse outcome. Perineural invasion is an established independent indicator of a poor prognosis, and the prognosis is more relevant in stage 2 disease. Coming to the resection margin, the proximal and distal margins are usually not much of a concern. Proximal or a distal margin of 2 cm is considered adequate. For T1 and T2 tumors, 1 cm clearance may be sufficient. If the carcinoma is rising in the background of inflammatory bowel disease, the proximal and distal resection margin should be meticulously evaluated for dysplasia and active inflammation. So coming to the resection margin, the circumferential resection margin that needs to be evaluated diligently. The serosal surface does not constitute a surgical margin. So the figure A is a reminiscent of a transverse colon or a sigmoid colon with a mesentery. And so this dotted line is the mesentery cut margin, which is relevant as a margin. This is an ascending or a descending colon. So here only the posterior bare area dotted line are considered to be the margin. Rest all is the covering is the serosa. And this is the lower 1/3 of the rectum. The whole circumference of the lower 1/3 of the rectum is a circumferential resection margin, as it is devoid of serosa all around. So a positive radial margin or a circumferential resection margin, the tumor less than from 1 mm from the non-peritonealized bare surface is considered as positive. The positive radial margin in rectal cancer increases the risk of recurrence by 3.5-fold and doubles the risk of death from the disease. A positive CRM can be due to the direct extension, tumor extension, or the tumor within the lymph node, veins, or lymphatics, or around the nerves within 1 mm of CRM. Now, the type of tissue affected leading to a positive CRM should be specified in the pathology report for distinct prognostic implications. Like metastatic lymph node, LV emboli within 1 mm of margin was associated with a much lower risk of local recurrence than a positive CRM due to direct tumor extension. Coming to the tumor budding, it is a well-known independent adverse prognostic factor. The presence of single cells or a small cluster less than equal to 4 cells at the advancing front of the tumor, which we report in a selected hotspot at 20x microscopic field, and 3-tier scoring is recommended, comprising of low, intermediate, and high, depending upon the number of the buddings. So this is the microphotograph showing the, so this A photograph is showing no tumor buddings. As you can see, there is a good circumscription of the tumor from the adjacent stroma. Here one can see 2-3 buds are there. So it's a low grade. This is showing 4-5 buds. So it is considered as an intermediate grade. And here it is showing a lot of single cells. So these are high grade tumor buddings. So what are the clinical implications? The patient diagnosed with colorectal carcinoma with submucosal invasion, that is PT1, in the endoscopic polypectomies, the tumor buddings are associated with increased risk of lymph node metastasis and hence a subsequent potential surgical candidate. Stage 2 colorectal carcinoma with a high grade tumor buddings, they show worse disease-free survival. Hence, it is useful to select the patients for adjuvant therapy. Coming to the tumor regression grade in the post NSCT specimen, the NSCT followed by, for the downstaging followed by curative resection has been established as a standard of care for the patient with a locally advanced CA rectum. Now, pathological complete response is associated with significantly better prognosis. Minimal residual disease has been shown to have a better prognosis than gross residual disease. So what are the special considerations for the tumor regression grade evaluation? If the tumor is grossly visible, a minimum of 4 sections need to be submitted. However, if there is no residual tumor on gross inspection, then entire tumor bed that needs to be submitted before labeling it as a pathological complete response. The acellular pool of mucin is not considered as a viable tumor post-chemotherapy, and tumor regression grade should be assessed only in the primary tumor. The nodal metastasis should not be included in the assessment. So these are the some popular grading Mendard, Rians. So what we are following is the based on the CAP AJCC, which is also known as modified Rian tumor regression grading. So grade 0 is when there is no residual tumor. Grade 1 when you have only a single cell or a rare small group. While grade 2 when you have more than single cells or more than a rare small groups of cancer cells. And grade 3 when there is an extensive residual tumor without any. So it's not showing any good signs of regression. So coming to the last aspect, histopathologically, that is the regional lymph node assessment. We are all familiarized with the end staging, which is based on the recent WHO and the College of American Pathology, which we are following. So just a special attention to the N1C category. So this is the category when there is no regional lymph nodes are positive, but there are tumor deposits in the subserosa, mesentery, or a non-peritonealized pericolic or perirectal mesorectal tissues. So what are the some special consideration in the evaluation? The lymph node status is a major determinant of the post-operative treatment. Patient with the positive lymph nodes, stage 3 disease are offered adjuvant chemotherapy. The National Quality Forum in US lists the presence of at least 12 lymph nodes in the surgical resection among the key quality measures. And the lymph node metastasis frequently involves small lymph nodes, even less than 5 millimeters. So hence all the possible lymph nodes that needs to be retrieved and examined. So a yield of minimum 12 lymph nodes are just the passing marks, and it should not be equated with the merit. The clinical outcome in stage 2 disease is actually linked to the lymph node harvest. The subset of stage 2 tumors with low lymph node yield less than 12 would represent a missed stage 3 tumors and behave as such. So the post-NACT specimen, a yield of at least 8 lymph node in a surgical resection specimen is considered satisfactory. So the factors that influence the lymph node yield, it could be surgeon based, like depending upon the length of the specimen we get, then pathologist related factors like the skill, the diligence, the method used in retrieving the lymph node, and patient associated factors like obese patient, elderly patient who have received NACT. So the yield will be fewer in these cases. So these are the predictive biomarkers testing in colorectal, some established and some emerging. So molecular profiling will be taken by my colleague, Dr. Sumit. So I'll just talk about the MSI because we are doing MSI testing on the histopathology report. So MSI by immunohistochemistry, we are doing and we are basically assessing the MMR protein expressions. So MSI is caused by the mutation in the MMR gene with consequent inability to correct the DNA errors that takes place during cell replications. So genes are inactivated either as a result of sporadic MLH1 promoter hypermethylation or germline mutation in MLH1, MSH2, MSH6 or PMS2 genes, which is the Lynch syndrome. So in 2019, NCCN recommendation that MSI status should be evaluated in all newly diagnosed colorectal carcinoma cases. And that's our institutional policy. We are doing MSI testing by immunohistochemistry in each and every newly diagnosed case. So this is the two types of reportings are done, which is the dichotomous reporting. So one scenario is when there is no loss of nuclear expression of MMR protein on IHC, we label it as a MMR proficient, and this has a clinical implication of having a low probability of MSI high. And the second reporting is the loss of nuclear expression of one or more than one MMR proteins, which we label it as a MMR deficient, and it is significance of high probability of MSI high. So this is the case of a MMR proficient, where you can see that the left side of the slide is showing the normal colonic mucosa and the glands and retained nuclear expression in the normal colon, whereas in the tumor on the right side, which I'm pointing, so the nuclear expression is very much retained in the tumor also. So this is MMR proficient. Now this is a scenario in which the nuclear expression is retained in the normal colon. It actually serves as an internal control, whereas the nuclear expression here on the right side, it is lost in all these tumor cells. So this is MMR deficient. So what are the advantages of the IHC testing for detecting MSI? It is readily available. The key advantage is that immunohistochemistry is to evaluate the individual gene defects and may strongly suggest the possibility of Lynch syndrome. The molecular testing by PCR reveals a MSI result may indicate either a sporadic MSI colorectal carcinoma or Lynch syndrome. Now, this dilemma will be there if IHC testing shows loss of nuclear expression of the antibody MLH1. But the great strength of the immunohistochemistry is that if the IHC testing is showing the loss of MSH2 or individual loss of PMS2 or MSH6, they are exclusively described for the patient with the Lynch syndrome. So with this result, you can stamp the Lynch syndrome and go for the family screening. So the advantage of the PCR testing is that it's quite sensitive and is able to pick up some 5% of the cases which are false proficient by immunohistochemistry. So this is the algorithm which we are following at our institute, and Dr. Sumit will be discussing about the molecular profiling. So what are the prognostic and predictive value of the deficient mismatch repair proteins or MSI high tumors? That they are the good prognostic biomarker for stage 2 colorectal carcinoma patients, because the adjuvant chemotherapy can be avoided in these patients where MSI high has been documented. The prognostic value of MSI is more prominent in stage 2 than in stage 3. And it also predicts the response to immunotherapy in patients with the stage 4 disease. So this was a very important study, the phase 2 trial, that documented that the mismatch repair status predicted the clinical benefit of immune checkpoint inhibitor with pembrolizumab. And now pembrolizumab is now approved in the patients with advanced cancer and MSI high status in a tissue agnostic fashion. So just to conclude, this is my last slide. Purpose of the standardized histopathology report is to provide all relevant diagnostic, prognostic, and predictive factors. A high quality pathology reporting is essential for optimal evidence-based management of the patient with colorectal carcinoma. All the challenging cases should be discussed in multi-speciality tumor board, and standardized histopathology report can help to exchange the information in the multi-center clinical trials and research studies. Thank you so much.